Today, we are making World AIDS Day with a conversation that really matters. I'm joined by Dr. Sherianne Kramer, a distinguished psychologist whose research and work focus deeply on stigma, mental health, gender, and sexuality. Have spent years working with communities deeply affected by HIV, including contributing to international public health discussion. We are incredibly lucky to have her expertise frame your discussion today. Thank you so much for being here, Dr. Kramer.
Thank you for having me.
Amazing. So if you could introduce yourself a little for everyone that is listening to us now.
Okay. Yes. So I think you did introduce me quite nicely, but maybe just to add on a little bit. Yeah, I've worked as a psychologist, mainly in forensics and research in South Africa, in a lot of low-income communities, often characterized by HIV and others. A lot of other kind of social inequalities and social strifes, but and political and racial inequalities, and with deep LGBTQIA plus issues as well. So a range of issues. In fact, often I felt I was more a sociologist than a psychologist. And then when I moved to Europe, I worked more in gender and sexuality, feminist theory, and then I moved into working with the World Health Organization, building interventions and deeply embedded in mental health interventions, but always kind of very focused on kind of marginalized communities and communities that don't have the same resources as more kind of resource communities. And it doesn't have to be financial resources, but I talk a lot about cultural capital. And when I talk about cultural capital, I mean kind of the resources like education, emotional support, psychological support, resources for help, emotional help, social support, quite a range of work. But that's what I do and what I have done.
Amazing and incredible, a social impact that you have in your society. Amazing to hear that and have you here with us today. As I identify as a gay male man, and I'm from '90s, so like HIV, AIDS, it was like used to be like a ghost, like hunting of the community, and I think well. I used to be Catholic, and every time that I heard that, I was like doing like the sign of cross, exactly the cross sign, because
stuff.
yes, and like I think we were facing like the peak of all the numbers, so that was like super new for us for back that time. So I'm really super interested with the conversation that we're gonna have today, because I think I also came from Brazil, so I think Latin countries, they are also like a little bit more affected. But well, I think the topic that we're going to discuss today is going to be like amazing for everyone that have the opportunity to go deep into this.
Yeah. Just a little bit about the history, I think, of HIV is really interesting, because I have a lot of medical colleagues who often talk about the fact that, you know, if HIV does become AIDS, it's actually something you can live with. Like, there is medication, there is support, there are ARVs, there's lots of ways to live a very healthy, full life and die when you're 100. And the real terrifying disease are things like cancer and diabetes, and that actually make your body and you suffer, and there's very little cure for it. And it's just about prolonging the life where you can. And hospice care, that's very rare now. Maybe perhaps in the 1980s, that's something we saw with AIDS patients, but that's not a thing now. And I think it's actually, for me, what I often see with HIV and AIDS is it's how we characterize it. So with cancer and diabetes, it's something that happens to you. People are like, oh, I'm so sorry. But with HIV AIDS, it's almost like you have to take the blame. You did this to yourself. And that is actually, I think, where the stigma started in the 1980s and 90s. It's kind of like, well, you know, this is your own behavior.
Yes.
And it's a very dangerous and slippery pathway down to like then creating, that's kind of where the stigma starts and gets really into murky waters, I think. Yeah.
And I think that affects like most, like a little bit like in a deep layer for the LGBT community, because you already have this 100%. Guilt that you're already like, oh, okay, I'm not straight, I'm not like following like the social standard outside. So you have like 2 layers of blame to yourself.
100%. And I think that it also, of course, culture matters a lot. So in America and Europe in the 1980s and 90s, when kind of the HIV realities were emerging, it was very much embedded in the LGBTQIA community. And at the time, LGB, because I don't think there was even a recognition of any kind of other genders, sexualities, that people could be multiple things and identify multiple ways. So really, really, but I would say mainly embedded in gay culture. I think that gay women escaped a lot of it, and gay men were probably at the focus of it. But if you look towards countries like South America, well, not countries, continents like South America and Africa and Southeast Asia, AIDS was actually the characterized poverty. So what started to happen where other people, had people who weren't part of a low income community, let's say in South Africa or Kenya, had HIV, then they felt like, oh, this is a sign of poverty. So different kinds of cultural things were happening. And I believe, I had quite a few colleagues who came from Ethiopia and Kenya. There was actually a really interesting work on kind of the intersection between being a Black African male, gay, and having HIV. Whoa. And all these kinds of like intersections of race, poverty, and homosexuality coming to the fore in the kind of focus on a disease. And I say disease like this because it is quite a social issue more than a medical issue, because medically, actually, it's actually very easy to deal with. It's a social kind of value and kind of, or non-value or worthlessness that is attached to HIV that becomes this kind of problematic, what we call discourse. And just to like kind of build on what you were saying, totally. And I don't think religion escapes it either, just to build a little bit on your, the Catholic point. Like, there is a deep-seated misconception of sexuality in much of the church, and it definitely trickles into how the church treats HIV.
Super. So following this way of thinking, so how you think the mental health and well-being for LGBT community people, like it's affected by that stigma?
Well, I have, I've seen with my own eyes. I'll use two examples. The first example is, so I'm going to talk about gender and sexuality broadly. I'll talk about sexuality in the first case, which you're talking about in the LGBTQIA plus community. I've seen how literally it is about my life is over. No one is going to love me anymore. I'm unlovable. I'm unworthy. I can no longer have children. I can no longer have a relationship. And what it actually, I think, in these communities starts to stir up is old mythologies about being gay or being lesbian or being queer. I can't get married. That is no longer a reality in most LGBTQI communities. But as soon as you start now intersecting with the AIDS virus, we're back to this kind of mythology about my body and who and what I can and can't do socially. So we kind of return to like all these original sinful ideas about sex and sexuality that we've tried so hard to kind of shed, and the kind of AIDS virus brings up these whole things. You shouldn't parent children if there's a lot of stuff around like gay communities parenting children, but one of the kind of terrible kind of notions is, gay parents are more likely to carry a virus, which is just an insane concept, completely insane concept. But that's part of this kind of stigma and discourse and construction. I'll give you another example from South Africa, which is a way more gendered example. But in some of the kind of low-income African communities that are still very, very ingrained in kind of old Orthodox patriarchal communities, men have multiple wives. And these women, I've sat and counseled like a group of women who are all HIV positive, and when I say to them, how's this come to be? No, well, my husband has multiple wives and can do as he wants. And he is actually, it's okay. He can be this virile carrier of HIV, but her body becomes tainted, which is really interesting in like the gender dynamic. And then to kind of take it a step further, which is a very unique experience in South Africa, is there's something called corrective rape, where women who identify as lesbian are raped by heterosexual men to correct their sexuality. And many of these women contract HIV. And what is insane is that it's still kind of characterized as a lesbian problem rather than coming from a heterosexual male non-consensual partner. So
Gosh.
really interesting how the HIV pandemic has given us almost the tools to manipulate more stigmatizing constructions around the LGBTQIA community.
And increasing that feeling that we already have just to be part of the community, that you feel like erased, like deleted from the society because of all those stigmas, because of all of those layers and intersectionality that you mentioned. It's been tough.
Yeah, 100%. And unfortunately with the AIDS virus, because the idea is that it is, well, the reality that it is, it's spread through particular physical contact. There is also like serious miseducation. So people are like, physical touch or kissing, or, there's like people don't realize that it's like literal swapping of bodily fluids. Like there's a whole lot of things that can happen before that is not going to lead to you contracting HIV. And that kind of thing also means that, like, people who carry if you have HIV, you carry this kind of, my body is tainted, don't touch me, I am, I'm virused, which is not true of other diseases, which to me is very strange.
I remember like this very famous video from the Princess Diana, like holding hands of patients with the virus, and that was like mind blowing for that time.
Yeah, in the 1990s.
Yes, exactly. Like, oh my gosh, a prince is like doing this, but this is not. You cannot take it just to look to that person.
Yeah.
Crazy times.
Yeah. But I think if we just go back to psychology of it, for me, what the most dangerous outcome is that there are a lot of people who then contract HIV and don't tell anyone and don't get the help that they require. And then what happens is it's almost like it's a self-fulfilling prophecy where AIDS does destroy your body because you never got help for when it was just HIV. And so it progresses to AIDS, a full-blown AIDS, and you haven't gotten the medicinal and social support. And that's also, like, I think for me, one of the biggest reasons to try and reduce stigma, because it means that people can access resources and then they never have to have full-blown AIDS. They can very easily cope with, having HIV.
Ignorance is driving us, like, from one point to another one. Yeah, I got it. Thinking about like the workplace, how colleagues and friends can show genuine practical support to someone living with HIV?
Yeah, I think this is a really hard question, because I think it depends on obviously what your workplace looks like. Corporate culture is very different from a small agency, is very different depending on the sector. And so obviously the actual workplace environment will be different and corporate cultures will obviously be a little bit colder than smaller environments. But I guess the key thing is to give people firstly the absolute reassurance that if they are going to disclose, that it is safe, it is confidential, and it is not to be weaponized. It is only to be supported. Like, for people, it is so terrifying to disclose, because am I going to lose my job? Am I going to lose my colleagues' friendships? Am I going to lose my placement? Am I going to lose the fact that I might be promoted?
People, you treat me in a different way.
Exactly. So it has to be, if there is disclosure, that person needs to be reassured from the beginning, and that reassurance needs to be demonstrated that it will not impact their career and that it will be held in confidentiality. I also think, but I'm biased in this way, that there should be some sort of psychological support in every work. And that doesn't have to mean that there needs to be a psychologist sitting in every single agency or corporate environment, but that there should be access to those resources, because the people who are going to be disclosed to about this don't know how to cope with it. So not just only for the person who's living with HIV, but for colleagues and the people in the work environment, to have someone to go to and say, I have a colleague who has HIV. I feel really guilty. I don't know if I'm treating them appropriately. I don't know how I should behave. Can you support me? So it makes people way more accountable if there is a kind of objective outside body to be able to talk to and get support from. So that's, I'd say, the two key things. But the kind of main thing is to not stigmatize it, is to create an awareness in the workplace about the realities of HIV and to debunk some of the myths, and hopefully all the myths. And part of that, I suppose, is about embedding education in the workplace. And that is difficult because people are like, we need to focus on our work topics, not on the social issue. And something South Africa requires of businesses is that they have a social responsibility component to their workplace. They can do whatever they want with it. They can donate to a charity, they can go paint a school, they can, whatever. But it kind of does make businesses go, oh, we should still be socially responsible and psychologically responsible. We were doing last year at the WHO a huge project on mental health at work. And it was so obvious that mental health is not important in the workplace. And we were feeling the same at the WHO, in a place where we were the mental health team in the WHO.
Whoa.
A lot of things we picked up that we didn't feel were like, we were also succumbing to some of the problems. And we realized it has to also start with ourselves. So I guess, it's nice to have this podcast, but then it's also got to be a place where we go, how are we helping? How do we adjust? Because if we're thinking about it, we're probably the shift and the change, but we have to make the change.
Yeah, thanks so much for sharing this. And from the psychologist's point of view, why you still like those old stereotypes and stigma? Why they still persist, even with the science already has moved on?
Yeah, I think again, it's different across cultures. Like in places in Africa and Asia, it persists because the social norms persist. So the socioeconomic differences, and so those things persist, and people are continuously lacking education, and the lack of education means they lack awareness. So it's really easy to understand in those locations why those kind of stigmas persist. But in our environment, in like high income spaces in Europe and North America and other northern hemisphere parts of the world, like it shouldn't be a reality that stigmas persist, but it is one of the hardest things to get rid of, are ingrained constructions. And I'm going to use a really easy one, gender, because it's so easy. We have since 1920 been thinking about women and men as like two binary elements in the gender dynamics. And we have called for shifts. We've spoken about, oh no, we can see ourselves on a spectrum of genders. We can look at women and men differently. Men can be emotional, women can be strong. And we've tried to disrupt these gender norms. And I'm using the binary because it's the most obvious. And no matter how hard we've tried to disrupt them, people will return to them very quickly. It is very difficult. It doesn't matter how, for a very clear example is women in work. It doesn't matter how high up a woman gets in their career, there are still elements of womanhood that are attached to her in the way we think about her. If she is emotional, there is some connection to her femininity. Whereas if a man is emotional, it might just be that one instance. And so stigma is attached to the way we construct things. And so it is so hard to erase. The only way of erasing it is replacing it with a different stigma or a different social construction. So what we have to do is socially construct HIV in a completely different way and basically burn it into the public consciousness, the way that it was originally burnt into the public consciousness. So, and the only way we do that is through a kind of ground up approach. In South Africa, another really good example, in South Africa, the Sexual Offences Act changed in 2007, where rape can mean anything, where one body penetrates another body. Gender is irrelevant, age is irrelevant, it's just body on body and penetration. If you ask a South African on the ground what rape is, 99% of people will say it is a man raping a woman. And he has to use his penis. And it can't just be an object. And that is insane because 2007 was when that law changed. And so the people who go to jail for rape aren't always the people who are committing rape. So it's actually about, it doesn't matter if the law changes or the government changes, actually grassroots stuff that matter more. And that's actually why I really like I think that social media is really powerful. It's dangerous as well, can be very dangerous for
Mm-hmm. Mm-hmm.
information. But if done well, it is a powerful platform to create awareness. And it's also one that is accessible no matter where you are. Even in rural populations on the planet, people have mobile phones and data. They might not have food, but they have data.
Yes.
So,
Yes.
is one way.
And I think the first taboo that we broke with this podcast episode was like since the beginning, you said that people can live almost like close to 100 years with HIV, and I think it is something. It is a piece of information that most of the people that doesn't know.
Yeah, so how cool would like a social media storm be on interviewing people who are between 90 and 100 living with HIV? Tell us your story. What a cool social media storm would that be? That's a kind of flooding of information that would be way more valuable. And to hear those people's experiences and how they lived and lived a real rich, full life despite what the social constructions would tell us.
Yes. And what impact does visibility, like seeing people openly living longer, healthy lives with HIV, have on reducing stigma and promoting acceptance?
Yeah. So I think visibility works both ways. So I was actually talking about this with you earlier, like the markers of HIV
Mm-hmm.
different in different populations. Certainly in the 1980s, visibly gay men, immediately people would be like, oh, they must have HIV or they are prone to HIV. Similarly, in Africa, I know that very young girls who are pregnant, people often assume have HIV because they've been sexually active. And so they're markers like that people make the assumption they are HIV. I did a really cool exercise with some school children in South Africa years ago, but it was so impactful. And it was based on the idea of visibility and body markers. And every single child had to say, I am HIV positive until proven negative. And the only way they could prove negative was by getting tested regularly and at the window periods. And if they broke the testing periods, then they'd have to say, I'm HIV positive until proven negative. And so what it forced them to do was to occupy the body of someone with HIV. Because if you're saying I'm HIV positive until you've proven that I'm negative, then you wear the brand. You wear the brand of HIV. And it completely changed these. And they were children. They were like between 10 and 15. And it completely changed their own concept of like, as soon as you go, and you identify with something, it disrupts things because you don't want to be stigmatized. So you're like, what would I do so that people don't? What would I do if I am HIV positive and I have to say I'm HIV positive? What are the things I don't want people to do and treat me as? And so then they say, oh gosh, well, I treat people with HIV in these ways. I don't want people to treat me that way. So that was really powerful. So it's about like really embodying that kind of idea that it could be me, it could be you, and how do I want to be treated, and how can I treat the other, in the same way. And yeah, I guess it's about taking negative markers, like the idea that a gay man who's wearing certain clothes or a young woman who's pregnant might be markers for HIV. What about, an old man who has grandchildren and a family around him? Why can't that be a marker for someone who's lived a very full, rich life with HIV? It's also about creating awareness that like HIV is not only a sexually transmitted disease. There are other ways to contract HIV. There are a lot of children who are born, with HIV through mother-to-child transmission, drug users. There are many other ways that people can contract HIV. And by embedding it only in sexual circumstances, it kind of locates in certain populations and dismisses the fact that it also affects other populations. And it invisibilizes those populations. So drug addicts don't get the kind of HIV, medical resources that maybe other populations do because they're completely not part of the discussion.
Totally. Whoa. It's so deep. It can be so deep. Yes, but I'm loving to have this moment here, like in the planner, like we set this space to discuss this because I think people are not normally like searching for this type of content. So I'm in love that we are conducting this podcast today. And my last question, and then I can open the space for you to share any other topic that comes to your mind. But what role does exposure to people with lived experience play in breaking down stigma?
Yeah. So in the work that, I've been recently doing at the WHO widely in mental health, not only, in HIV, but widely, is what we're finding is that it is very hard to explain and educate at a theoretical level. People cannot empathize with stories that are kind of written down, or even, stories that are like, just fed through textbook. As soon as people with lived experience come and talk, just talking, there is a shift in attitude. And one of the earliest and easiest ways to shift attitude is to expose people to anything. It could be videos, or documentaries about people living with HIV, but it could also just have, one person coming to talk. Like, we're very big on the fact that, like, if you have an HIV intervention, you should have people living with HIV helping give that intervention, delivering the kind of care that they also would like to receive. So, and the idea is also peer-to-peer support. So HIV people meeting other HIV people and sharing war stories, really. And that's very powerful. And I think it's sometimes more powerful than therapy to be in a peer group with shared experiences, shared lived experiences. I also know that what we know in psychology is that if your attitude shifts, that can also then lead to knowledge and behavioral shifts. So if I have an attitude where I have a particular idea about HIV, my behavior will match that. So I will not only look at someone with HIV in a particular way, but I'll behave a certain way towards them. If my attitude is shifted through my interaction with people living with HIV, my behavior will start to change and my knowledge starts to change. My knowledge shifts. So I'm like, oh, HIV is not what I thought it was. It is something else. And so, and when you shift attitude, knowledge, and behavior, then you actually shift people's complete way of like being towards each other. So I think that it's very powerful. Like people with lived experience are probably our most powerful tools.
I think the biggest takeaway that some people could take from everything that we shared, that like having HIV or even like it evolves to AIDS stage, it's not like a death sentence.
No?
We need to humanize them.
Yeah. It's definitely not a death sentence. And I mean, one of my friends who's a doctor always says like he would rather contract HIV than ever be diagnosed with cancer. And I think that's very telling, because we seem to treat HIV and or AIDS. And that's also another thing. People don't understand the difference between HIV and AIDS.
Perfect.
And that there is progression and that, the one is not the other. But people do treat it as a death sentence and like your life is over. And it's just not the case. And there are plenty of people who live very full lives if they access the resources available to them. And I think that's like a really important take home.
Fantastic.
Yeah.
Dr. Kramer, do you like to add any other thing?
No, I hope that this does start a really good conversation. I think, the idea that this kind of platform can have impact is very real. And I think that the more people who are exposed to conversations and are interested in conversations, the kind of more we shift as a community. So I also think that World AIDS Day is also just a nice time to like reflect on actually not just the negatives, but how far we have come. So yes, the stigma persists, but there are also a lot of shifts in awareness, and there are a lot of people who are being very open about their own experiences. And I don't think we're in 1992 anymore. We are for sure in a different place. So
totally.
We can also hold on to that and hope that if we speak again in 3 years' time, we've shifted even more.
I hope so. Let's have this as a commitment.
Yes, I like that.
So, Dr. Kramer, thanks so much for sharing your experience and wisdom with us. We hope this conversation has helped all of us to understand the experience of people living with HIV, the power of empathy, and also the importance of reducing stigma. Thanks so much for your time.
Thank you.